morning and welcome to session one of our data sciences conference with Temple University. And our first session this morning is very topical given the times in which we live. Our first session is leveraging COVID-19 data for quantitative investing. And moderating and hosting today's, all of today's sessions for that matter, is going to be Edo Arioldi from Temple University, where he is the professor of statistics and director of the Fox Data Science Center, excuse me, Edo. Also joining us this morning from Yale University is Nicholas Christakis. And Nicholas at Yale is a Sterling professor and co-director of the Yale Network Science Institute. We are also very fortunate this morning to have David Madigan. David comes to us from Northeastern University, where he's provost and a professor of statistics. And also joining us, we are very fortunate to have Ben Yu. Ben comes to us from the University of California, Berkeley. Ben is a professor of statistics and a Chancellor's Distinguished Professor. We thank you all for participating this morning, and we're excited to have you. So, Ed, I'll turn to you, sir.
Thank you, John. I also want to chime in and welcome our distinguished faculty guests on behalf of the Department of Statistical Science here at Temple University. So thank you all for being here. As John mentioned, today's panel, first session is about COVID and COVID data and meta-analysis involving complex data sources. So the first speaker is going to be Nicholas Christakis. Nicholas is an expert of COVID. Back in April, he published one of the first papers tracking the epidemic in China on a journal called Nature. And he has recently published a book titled Apollo's Arrow that's been translated in 5 languages and counting on COVID. So Nicholas, welcome and thank you for being here. I'm going to turn it over to you.
Thank you very much for having me, and thank you to my fellow panelists. I'd like to spend the time that I have with you talking a little bit about some basic epidemiology about this pathogen, and summarizing some of the work we've been doing using a variety of data and statistical techniques, and then close with a little bit about what I think is likely to happen in the coming 4 years as this pandemic continues to afflict us. So something very unusual has happened to us as a species. We happen to be alive at a moment when a new worldwide pathogen has been introduced into our midst. This doesn't happen very often, maybe every 50 or 100 years. And this new virus, this SARS-CoV-2, is going to be with us forever from now on, circulating among us. And in fact, the way we have come to live in this time, in our time in the pandemic, may feel, it probably surely does feel, very alien and unnatural to us. But it is actually neither of those things. Plagues have always been a part of the human experience. What's happening to us right now is not new to our species. It's just new to us. We think this is so unusual, so weird, so intolerable in a way, but actually our ancestors have been dealing with plagues for hundreds or even thousands of years. And by this time in the course of the epidemic, 9 or 10 months into the pandemic, we know quite a bit about this pathogen. We know, for example, how lethal is the pathogen. A recent sophisticated meta-analysis of many studies has revealed that the infection fatality rate of this pathogen is between 0.5 and 0.8%. And actually, if you develop symptoms of the pathogen, because only about half the people develop symptoms, you have to double those numbers to about 1 to 1.6%. Let's say that about 1% of people who get this disease and get symptoms from it die. That's a non-trivial infection. It's not as bad, of course, as smallpox or cholera or bubonic plague, but it's still not trivial. Furthermore, at this point, we also know, and the mortality depends very sensitively on age, as most people know. So that, for example, if you're in your 20s or younger, you might have a 1 in 3,000 to 1 in 5,000 chance of dying of the condition if you get it. If you're middle-aged, maybe a 1% chance. If you're 75 or 80 or older, maybe a 20 or 25% chance of dying if you get symptomatic COVID. We also know some other things about the pathogen. We know how infectious it is. This is known, as everyone knows now, by the so-called R naught, the R sub zero, the basic reproduction number. That's a measure of the innate capacity of the pathogen to cause new infections in a wholly naturally interacting host that is non-immune. So when the epidemic first starts, what is the intrinsic capacity of the pathogen to infect more people? This number is between 2.5 and 3.5 for this pathogen, probably between 2.6 and 3, let's say 3. So 1% case fatality rate, basic reproduction number of about 3. But this pathogen has some other sneaky qualities we've now also been able to ascertain. One of them is its ability to cause super spreading events. And this can be measured by something known as the dispersion parameter, or kappa, and was beautifully discussed in a paper by Lloyd Smith in 2005 in the journal Nature. And so to get a feel for this, I'd like you to think about the following alternatives. Imagine you have 100 people in a population, and each of them, if infected with SARS-CoV-2, could infect 3 new people. So the R naught would be 3 in that population, but everyone has the same R naught. Now imagine another population of 100 people. 99 of them can infect no one, and 1 of them can infect 300 people. They're like a super spreader. Again, the R naught in that population would be 3. Now, you should have the intuition that in this type of a situation, if a person from the first population migrates and goes to a new location, it will inexorably set into action of the epidemic. They will infect 3 people, and those people will reliably infect 3 people, and so forth and so on, and the epidemic will continue. But so there you have a very small dispersion. Everyone has the same R naught. But in the latter population, you have a high dispersion, and there, if one person moves from this population of 100 somewhere else, 99 out of 100 times, the epidemic will dead end and will not continue. And this is, in fact, one of the qualities of this pathogen. It has this variation in the R naught across people. Many transmission chains are dead ends, but we also have frequent super spreading events. And this has implications for how we manage the condition and for how we discern what's happening. And finally, in terms of the introductory epidemiology, but I could keep going, but I'll just mention one more feature. This pathogen has a very annoying property of affording the opportunity for asymptomatic transmission. That is, the infectious period in an individual, the moment when they are able to transmit the disease, often arises before they themselves have symptoms. Now, this is not always the case. For example, if you think about the disease smallpox, people with smallpox cannot transmit the disease until they develop pustules on their body. So we can use their symptoms to discern who is infected. Conversely, if you think about HIV, people with HIV can be completely unaware that they have the virus and spread it for years before they get symptomatic. SARS-CoV-2 is like HIV. You can spread it before you have symptoms, and this makes it very difficult to manage. In fact, many studies now suggest that up to 75% of cases of SARS-CoV-2 arise from asymptomatic transmission. And before continuing, I want to say one other thing about this pathogen, because it's just dumb luck to us that the pathogen is not worse. There's no God-given or intrinsic reason that this pathogen couldn't be infecting killing 10% of the people who get it, or 30% of the people who get it. We could, in fact, have been facing a worldwide bubonic plague type situation. And many experts have been fearing these types of respiratory pandemics for a long time, and fearing that they would be even worse than what we're facing. So bad as COVID-19 is, I want people to realize it could have been worse. The disease could have been more fatal or more transmissible, or both. And we're just lucky that it is not. Now, as Ido said, my own work in this began in January, and I'll just summarize a few big data projects we're doing because they provide some insights into how you could use data techniques to track and forecast the course of the epidemic. One of the first things we did was, beginning in January, I had some Chinese collaborators that I've been working with for a long time, and we've been using anonymized Chinese phone data to study a number of social phenomena. For example, when there's an earthquake, how does an earthquake reshape human social interactions? Or if you build a high-speed rail line, how does a high-speed rail line change interactions and therefore prompt economic development? And we were using phone data over large spans of time to study these phenomena. And in January, I was speaking to my colleagues in Hong Kong at the Chinese University of Hong Kong and at Hong Kong University, and some other colleagues from mainland Chinese universities. And we decided that we could use these data to track the course of the epidemic in China. And what we had is we had phone data regarding the physical transits of human beings through Wuhan, which for hundreds of years has been a central transportation hub in China, as luck would have it. We were unlucky that the virus leapt to the human beings in a very large city that also happened to be a transportation hub. And it would be like, well, anyway, I was going to compare Wuhan is like New York City versus the virus, let's say, taking root in Bismarck, in the Dakotas, for example. So it was bad luck for us that it started there. And we had information on 11 million transits through Wuhan up until January the 24th. And we could see these people spread out across the country. And just using the phone data alone, just using information about the movement of human beings, we were able to predict the timing, intensity, and location of the epidemic up through the end of February in China. And we developed a model that allowed this forecasting, which we call the risk source forecasting model. And it can allow you, using human mobility data, to predict the course of an epidemic. But while I was working with my Chinese colleagues doing this, and that was the paper that Ido mentioned that we submitted February the 18th, it was actually quite an exciting moment for me in my career because I hadn't pulled all-nighters since I was in graduate school, but with my collaborators on the other side of the world, we were working 24 hours a day for 3 weeks to get this manuscript completed. But because I was so intimate by then, so aware of what was happening in China, by the end of January, on January the 24th, the Chinese were so concerned by the virus. After initially covering it up and doing a bunch of stupid things, they began to take it very seriously. And they were so concerned about it that they essentially detonated a social nuclear weapon. The Chinese put 930 million people under some form of home confinement, beginning January the 24th through the end of March and into April, which was astonishing. And this really got my attention. And as I was sitting at my desk at the end of January, I could think of no reason why the same thing wouldn't happen to us. There was absolutely no reason the virus would not come to us. And every epidemiological expert I was in contact with at the end of January felt the same way. So I became very concerned, and I began to direct my lab to begin to look at some of these topics. And we began to do a whole bunch of things. One thing we began to do was to look at the, because by the springtime, we had the primaries, the political primaries were taking place. And I was very concerned that turnout to voting, the assembly of people in polling stations, would contribute to the pandemic. And in partnership with Eric Feltham, one of the statistics grad students in my laboratory, we did an analysis of whether turnout to vote on particular days in particular locations throughout the country in the United States affected the trajectory of the pandemic in those counties, at the county level. And to my surprise, we found the answer was no. So when we started the project, I had thought that voting, turning out to vote, was a kind of mass gathering, and that surely could not be a good thing. Although back in the spring, the prevalence of the pathogen was still relatively low in our country. But it turned out that that was not the case. And I think part of the reason was that if you actually think about voting, and since then we've now learned a lot more about the virus and its transmission, people line up outside, for example, before they go inside. When they're inside, they're there for a very brief period. Voting is a private event. You're not face-to-face with other people. You're in a little cubicle. It's quiet. People aren't raising their voices or shouting, as we now know is a mode of transmission. And it's brief. You're inside only for a brief period. So that's another project that we did that we've now posted online, and if you're interested, you can look at. My laboratory also began to work with some of the software engineers in the lab to prepare an app, which we call Hunala, H-U-N-A-L-A, Hunala, H-U-N-A-L-A. This app is available on the Apple Store and on Google Play. It has thousands of users. It is like Waze for coronavirus. This is not a contact tracing app. It's not a backward-looking app. nor is it a citizen science app, which just has people report their symptoms for use by public health authorities. It's an app that users can actually use to forecast their risk of getting the virus by kind of like Waze. In other words, Waze, people are driving down the highway, you're driving down the highway and there's no police stop and there's no traffic jam where you are, but 3 or 4 miles down, people have reported that traffic is at a standstill. You can be notified about this, and then if you wish, you can exit the highway and avoid the traffic jam. That's sort of what our app does. It crowdsources information about the location of the virus, and based on where you are in social networks and where you live, it feeds back to you risk models and estimates of your probability of becoming infected with a virus in the near future. The app at the beginning, it asks to access your contact list, but we do not copy your contact list, and the app, if you allow it, accesses your contact list just to make it easier for you to signal who you interact with. It does not copy. There's no privacy consideration of that kind. And we began a number of other projects in the lab. As Ido mentioned, I decided to work on this book. And part of the reason for that was back in February and March, I was very concerned that our leaders in this country, beginning at the White House, were trivializing this epidemic. We're not taking it seriously. And I thought that there was a significant need for people to understand what was happening to us epidemiologically and historically, and that led to that other effort. Let me just say a few things more about the what I think is likely to happen in the coming years, and then I'll close with sort of one big idea. It's actually not such a big idea. It's just an idea. So earlier we talked about the R naught, and that for this pathogen it's about 3, and this property, the infectiousness of the property, is mathematically related to what is known as the herd immunity threshold. Herd immunity, as many listeners have probably been thinking about, is the ability of a population of people to be immune to a disease, even if not every individual is personally immune. So imagine, for example, you vaccinate 96% of people in a population for measles, and one of the 4% unvaccinated people gets a case of measles somehow. That person would be very unlikely to be able to start an epidemic because almost everyone they interact with is immune. So you don't have to vaccinate 100% of the people. Just vaccinating 96% of the people is enough to make the whole group of people immune. Well, you should have the intuition that the fraction that you need to vaccinate or that need to acquire immunity naturally is connected to how infectious the disease is. Measles is the most infectious disease known, so the herd immunity threshold is super high. Most of you know that for seasonal flu, nowhere near half or all of Americans get vaccinated every year. In fact, about 30% of Americans is enough. And that's because the R naught for measles, the basic for the flu, for seasonal flu, the basic reproduction number is about 1.5. So to calculate the herd immunity threshold, you use the formula R naught minus 1 divided by R naught. So if you plug in the number 3, which is the basic reproduction number, the R naught for coronavirus, for COVID, you get 3 minus 1 divided by 3, that's 66%. So the herd immunity threshold using the standard formula for this virus would be 66%. Now it turns out that that calculation makes some assumptions, something known as the well-mixed assumption. It assumes that everyone in the population has an equal probability of interacting with or becoming infected by everyone else. That is not true of real-world populations. And network science insights, including a whole bunch of ideas that Ido Aroldi has innovated in, suggest that that number needs to come down. So, in fact, the herd immunity threshold in the United States is probably 40 to 50%. Let's say 45% of people need to be immune in order for us to have herd immunity and reach that threshold. Well, right now, only about 12% of people in the United States have naturally acquired the disease. So we're still at the opening act of this pandemic. We've got a long way to go. We're not at the beginning of the end. We're just at the end of the beginning of this pandemic. And absent a vaccine, which I'll come back to in a moment, this would be the natural course of the virus. It would just spread and spread and spread until it reached the herd immunity threshold. Then the epidemic force of the virus would decline. The virus would still be around, but we wouldn't have this sort of escalating epidemic any longer. So what do I think is going to happen? As we've all seen in the news, vaccines are already in late phase 3 trials, which is just miraculous. Unlike our ancestors for hundreds of years who had no access to any effective treatments, we happen to live at a time when our time in the crucible of this plague, is when we actually can invent effective preventative measures like vaccines. So we've seen 2 so-called RNA vaccine trials release their results, and more vaccines no doubt will be released. Most of them will begin, or these trials will begin to be documented, these vaccines as effective, let's say in the first quarter of 2021. But inventing a vaccine and getting its approval is just the first step. Then the vaccine millions of doses must be manufactured, must be distributed, and most importantly, must be accepted by the public. And in my estimation, this will take substantial amount of time, maybe a year. So that gets us to early 2022, by the time we have vaccinated enough people with whatever vaccines we have available. Meanwhile, the virus is still spreading. So from my desk, 2022 is a moment when either we will have reached herd immunity due to vaccination, or we will have reached herd immunity due to the natural spread of the virus. And at that point, the biological and epidemiological force of the epidemic will now be behind us. But we still need to recover from the psychological, social, and economic impact of the virus. More than 30 million Americans are out of work. Many businesses have gone out of business. People are not going to instantly return to restaurants and airports just because we've reached herd immunity. It's going to take time. People are still going to be wearing masks. There's still going to be physical distancing. And if you look at historical epidemics, that typically takes 1 to 2 years. So I think that intermediate period is going to last till 2024. And then in 2024, the post-pandemic period will begin. Now, usually during times of plague, people, now, people get more religious, for example. People get more abstemious. People stop spending money. People get risk averse. These are all things that we're observing. People get lonely. These are all things we're observing in this pandemic as well. But what will happen in 2024 is that all of those things will now start reversing. People will relentlessly seek out social interactions to nightclubs and restaurants and political rallies and sporting events and mass gatherings. People will start spending money again, I think, quite liberally. There'll be a kind of joie de vivre and risk-taking, maybe some sexual licentiousness. In fact, one person read my description of what was going to happen, one reviewer of my book, and said, here's hoping that that's what will happen in 2024. So I think that is what's likely to unfold for us between now and then. Let me just close with one final set of observations, which is not strictly statistical or forecasting, but just has to do with where I think our country is right now. I think it's very important for people to realize that during a time of epidemic disease, there is no life without risk. Everything you choose to do, everything every firm chooses to do, necessitates weighing risks against each other. Even the 14-day threshold for quarantine is actually, there's a distribution of infectiousness. It's not like by 14 days, 100% of people are no longer infectious. Actually, at 14 days, 2.5% of people are still infectious. So you're taking a risk. Even if you do a 14-day quarantine, there's some small risk that actually that person could still infect you. And you have to judge. Do I send my kids to school? Do I go out shopping? Do I have my college-age kids come home for Thanksgiving, or do I not take that risk? Every single action that we engage in necessarily involves an assessment of risk. And this, therefore, requires us in our society, in my view, to be more honest and more mature about what we're facing. Nobody wants to have to face this serious calamity. But unfortunately, this is the reality of what we live in. And what we are being called for in our country and in all countries is to sacrifice, to service, to honesty, to concern for our neighbors, and for a willingness to work together to combat this virus during our time of plague. Thank you.
Thank you very much, Nicholas, for your very informed and scientific perspective on the topic. I really appreciate it. We're lucky to have you here. I'm now gonna turn it over to Bin. So Bin Yu has recently spearheaded a tremendous effort in her lab to collect data about COVID and to create a database of of reliable information about COVID-19. She also has recently published a paper about it in the Harvard Data Science Review that is linked in the content library that goes hand in hand with this event. So Bin, I'm going to turn it over to you. Thank you for being here.
Thank you. Thank you for inviting me. And it's really a great pleasure to follow Nicholas' very inspiring talk. And next, please. Slide. Yeah. So this is really something my group jumped in March when we saw all this coverage of PPE in badly need. And we usually do machine learning, statistical genomics, neuroscience, but this is something we felt that we could help. And when there was a call from Responsible Life, a newly established nonprofit organization, we jumped in. Next, please. So most of my lab joined, and in the summer, we're actually joined by people from Google as well. Next, please. Next, please. So that's the goal. And the first task we were faced was actually curating a data repository, because this is the first project we got done that we didn't have data. And we basically used whatever available publicly and use some also connections with colleagues like Sam from Northeastern. US Facts has, and also New York Times had the county level case data. We decided to go for the case county level because most people working on the state level. Since we want to distribute the PPEs across the country, we felt like state was not fine enough granularity. So we went for the county level, and likely there were data available. We also curated a lot of data, social health, and other factors we think might be related to the death counts. We also made a choice to go for the death counts instead of case as a surrogate to predict the need for PPE for different hospitals, because cases, as we know, that depends on how many cases, or how many tests were done. And that's their inaccuracies, but still a lot more reliable. And even though we don't have it at the hospital level, facility level, we have data on hospital like employee numbers, so we can kind of impute the need. Next, please. So here's a bird view of the hospital level, county level data. There are about 7,000 hospitals in the US. Each of the hospitals will have about 200 features about their locations, how many employees, how many beds, how many ICU beds, and their ratings, and the ICU occupancies. And on the right column, we also collected the COVID data, the deaths and case numbers, and also demographics, population density, age structure, as we know that age is a factor in death rate, health risk factors like heart disease, lung disease, smoking, diabetes, and also socioeconomic risk factors. So all this data is at GitHub that you can use for your own study and your understanding. We also have a website I'll introduce. Also, we start going for some mobility data, but didn't find it, all the data we had was too useful for the prediction at the county level. And so we keep collecting data. We have some Kinsa data, temperatures, and some flight information between different cities. So it's a pretty extensive database we curated. And it's automatically updated for all these dynamic numbers like case numbers and death numbers. Next, please. So there are data quality issues. And as we know now, there were undercounts of deaths. Like after April 14th, a lot of counts now have proper deaths, like New York City has proper deaths. Next, please. And we decided to go for US Facts because they both, and New York Times, come from the same source, basic county level deaths and case counts, but they probably scrape the county level data at different time, do different cleaning, so they don't always agree. The reason we went for US Facts because for US Facts, the different New York City is not just one number. They have different counties or different districts of New York City. So that's the reason, because at the time things were really happening in New York City. We didn't want to have just one big number for the so-called city. Next, please. And here just show you that, you know, most of the time they agree, but there's some differences and they can be as large as a few hundreds. But with like 3,000 counties, it's not too big a concern. Sometimes the revisions does cause problem for our prediction, but that's just something we have to live with, unless you have really quality control at each county level. Next, please. And there's also weekday effects, right? Next, please. You can see that the number of death counts, there's definitely a daily pattern, depends on which day of the week. We think this is probably reporting delay. People probably don't work over the weekend, and therefore the death count over the weekend got reported on Tuesday, more like Monday might be too early. Next, please. So there are also historical data revisions. Next, please. And there was one case that you can see this small number near 1,000. That was a case, I think was a human error. It's King County in Washington, where I think it should be like 500. Some deaths was entered as 1,500. So later got corrected. And because the correction, you have this stripe of data revision continuously revised. Next, please. So it's imperfect data, but that's the best we can. So we want to predict 5 or 7 days first, and now can also do, you know, 14 days short-term prediction. This really dictated by the group we support, because it's enough to do 5 days for the shipment of PPEs across the country. The source of the PPE come from the local makers who use materials to make these masks. And then we work with other organizations to ship the PPEs around the country. First, we develop many different predictors. And then we also have a pretty non-parametric way, just use the past prediction errors to come up with a prediction interval. And we still maintaining a website to really visualize our data and to have our information updated, more like automatic AI system to have, I'll introduce the website later. Next, please. So that's what we set up to do. So next, after we collect data, we continue to collect the data, create the data. We have actually a data team. So with 12 people before the summer, we had different sub-teams, data team, modeling team, like a reading news team, and other people just help along the way. So it's quite an interesting team dynamic, but people work really well. Basically, many of my students drop anything, like everything else, and we work on this from March to May, non-stop for 2 months, and continued over the summer. Next, please. So do a lot of courses in the Samsung, very dynamic data. And long-term prediction have to do with feedback. I think we still, the modeling community struggling with accurate or anything. There are different teams giving very different long-term predictions. And we aimed at short-term. And we want to do it for all counties in the US instead of a particular state. Next, please. But the blessings are actually, we have always feedback, like how well we do. So it's a great reality check. We have to keep us honest. And next is that for PPE supplies, we could, 7 days is good enough. And we actually can do 14 days reasonably well. Next, please. So we had different teams of people work on the develop many different predictors. And the idea is that we kind of have parallel people working. We have separate county at the time. When we started in March with exponential growth, we have exponential predictor. And then we have linear predictor, just past 5 days, fit a linear trend for each county. And then we also have shared like parameters across different counties in exponential model. And then the fourth one is we try to use some demographics and to see whether they'll improve. And then we also have the fifth one, which is just use the case and death numbers from neighboring counties and the county before, and also use the weekly effect 7 days ago, and then do the prediction. Next, please. And we have a way to combine. So this combination idea really came from 20 years ago when I was at Bell Labs. We're combining different predictions for audio compression. So this is really something you can put it under the minimum description length principle. Idea is very straightforward and simple. You just look at the last few days. You have discount factor mu in the past, like a month ago, how well you did doesn't matter too much. You just look at the past few days and you give more weight to predictors where it worked well for the last few days. And then you weigh them exponentially with the error. And then you have C control how much you want to put with the best predictor versus the others. So that's worked really well for audio signal. We fixed the mu and C from that paper because I was really worried about overfitting. And the reason why it works here is that audio signal with both lyrics and also music was very dynamic and changing all the time. This is before podcast time. At the time, we want to support the podcast over internet. And this is just signal, very signal processing or machine learning approach. Next, please. In the end, we end up using the square root because some accounts can have a long tail. We try to make things a little bit more comparable. We took a square root of the counts and use this as the error, which is all the numbers, 0.5, C was 2, and mu, I think we use 0.5. And then we can combine all the 5 predictions in a way. But it turns out 2 of them work much better. So we end up just using 2 instead of all the 5. So there was this kind of screening using the data we had. Next, please. We end up using number 2 and number 5. Number 2 is just very simple, linear, use 5 days, do a linear prediction. Number 5 takes a little explanation, but intuitively, it's kind of using the loss function from a Poisson regression as a machine learning surrogate loss function. And we use yesterday's death count, and 7 days ago, the case count from the same county, and the neighbor death count 7 days ago, and neighbor county add up case numbers 7 days ago, and that's it. And we share all the parameters across different counties. And we use the weighting scheme we call CLAP now from the earlier audio compression paper, and that's what we end up using prediction up to today. Next, please. So when things are linear, we kind of put more weight on the linear predictor. When things are more exponential, we put more weight automatically. This is not humanly tuned. So here you see 3 plots. Just let's concentrate on the first plot. This is just a raw scale absolute difference between your prediction and the past, and over across different days and across different counties. This panel or plot try to show you that the combination really worked. So the red corresponds to the linear predictor, and the kind of yellowish is the exponential shared, and the blue is the combined. So most of the time works better. And the last one is the most interesting because this is using the scale square root as a measure of prediction error. That's what we use in the weight. So you can see the advantage of the blue curve is much more obvious. But it's interesting to see that for the 2 other errors, one is just absolute difference, the other is relative error, with the blue curve still turned out to be the lowest. In the beginning, you can see there's a lot of variability, and just we couldn't have much data to really do well, but eventually it's also because the total number gets big, we get a pretty good handle on the total accumulated prediction error. Next, please. This is using the same color, but the same matrix for 3 curves, but the curves mean different things. We're looking at different horizons. 7 days is the lowest, yellow 10 days, and blue 14 days. It shows that for all different 3 metrics of prediction error performance measure, it's very obvious that it's harder to do 14 days than 10 days than 7 days. And next, please. This is just to show you that if you push to 21 days, there's kind of a linear rise, right? It basically you pay a price when you go more into the future. The way we do it is actually we do the second-day prediction, and then we use the past pretending the second-day prediction become the real prediction, and we just keep bootstrapping up for future days. So the method works. You can keep going, but just the reliability, because the dynamic of changing dynamic of feedback loop, the method is not able to predict into the future because we don't take into account the feedback loop. But on the short-term scale, there's implicit taking into account the feedback loop, because we just see the trend of where the death count is going. So it's not a big problem without explicitly modeling the feedback loop. So I think this is more signal processing, machine learning, or statistical approach. It's a good complement to the more agent-based approaches, modeling explicitly the interactions, the networks. And for example, we could possibly combine for short run and constrain the other models, which is more involved, with this more straightforward trend following approach. Next, please. So I have talked about the predictors. We end up using 5 when we develop. We end up using 2 instead of the 5 we developed. So the next thing we wanted to do is give you a prediction interval. It's not enough just say, well, it's about 500. If you want the hospital to be like prepared, you want to give some interval so they know that really they should prepare for 500 beds, or they should prepare for just exactly 300 or 350. So we're going after interval prediction. Next, please. So the idea we use is very simple, can be put really under the conformal prediction. This is all data you can see. Santa Clara, that's where California had a lot of cases and death relative to the other counties. We just look at the last 5 days and look at the relative prediction error for our method. And that would take the maximum. Next, please. And then we just add up to the prediction, top and bottom. Since we're looking at the cumulative deaths, if we go beyond the last death we observed, we should definitely truncate there instead of just going below. And that's the interval we get for the prediction error. And we can do some calculation. If the prediction error in terms of relative scale are exchangeable, you can show that this way we'll get about 83% coverage. So that's kind of a rough calculation. And next, please. This is to show that if everything's exchangeable, you show the ranks of the different residuals will be more uniform, and between 1 to 6, so the average 3.5. This gives you some indication. On average, we kind of okay, but there's variability. But the proof of this method is not really the theoretical calculation. It's really, we can just see how this interval really cover the observed death counts, because we have many, many days to come and many, and that's what the empirical measure in the conformal prediction analysis. Next, please. So here, see, if you look at the period, the first period, April to May, then the coverage, we aim at 83% under some, observed seem to be okay assumptions. And most of the intervals coverage is actually above 80%. There are a few below. And if you look at it, it's because a lot of times there's a sudden jump. Either just something happened, there's a super spreader event or something, or it's because a revision of death count. So and then the method have a hard time catching up. And if you look at the May 11 to 12, the coverage is still pretty good, but the intervals are relatively long. But if you only look at the days where you have enough deaths, that's what we're really aiming at when the PPE will be in shortage, then the interval size is a lot more decent. Next, please. Next slide, please. So now we have seen that we have now an interval which has pretty decent coverage. Then we move on. Chandon, actually is my deputy, a CS student in my group, start building a website. And we start displaying a lot of our results at our website. So that's still up, called covidseverity.com. Next, please. So this is behind the covidseverity.com. It's really an automated AI system. We did curation of the static features about health and density, economic, socioeconomic situation, all of that. And that's already put in there. We're still adding some things when there's opportunity. But the daily counts are scraped automatically from US effects. And we do some automatic cleaning, as I'll show you, that doesn't always get to the problem. Like this 1,000 like change, if you human look at it, you know that it's an error, but the machine didn't know. And then our CLAP prediction algorithm runs on automatically using AWS. So thanks to AWS for supporting us. And also we have our MAPI intervals also calculate. MAPI means you use the maximum of the past prediction errors. And the AI system could not spot the problem, as I mentioned, that the King County, Washington was just later got corrected. So humans in the loop would be better. So I have been kind of the only human in the loop. Each time I give a talk, I look at the website and spot something and then let the people fix it. So I hope more people look at it. And there was one person actually just somebody out of blue really helpful, find some also debugged for us too. So we really need a human in the loop, but right now it's mostly the machine doing the job. I'm the only human go there while I give a talk. Next slide, please. So I see the future of AI as human-machine collaboration. So this is just a snapshot of a website. That's the front page. We have on the left is the total cumulative number of cases, because I have to submit the slide earlier this week. So that's where I did the 12th last week. And you can press the blue button, which I'll show you. On the right-hand side, I'm trying to go a little causal, but not quite there. So did a little work, hope other people find useful. Give you a way to cluster different counties and do some offset when there's 1 or 2 cases. Or you just say, that here's the county, find the 5 counties most close in terms of the trend. So some minimum ability to cluster. It's beginning of I'll say causal investigation, which is very difficult. But if you use the operational definition for causal inference, which is you want enough evidence to act, then we're definitely in causal inference, not in terms of mechanism drive, but I like that definition. I think it's from Nancy Cartwright from Stanford, and this is where I read her paper. It's just like you want enough evidence to act. And that in that sense, we are in a causal inference framing. So we have some data over the summer on the policies, but we haven't really done much except putting this out. Hopefully other people find it useful too. Next, please. So you press the left button. We have 8 metrics to really show you the map, right? This is November 12th. You have cumulative cases, cumulative deaths, new cases, new deaths, and normalized by 100K. This is what our press is, new cases per 100K. This is November 12th. And then you can also do a search. I put there Philadelphia County. You can also go to county. And on the left, we have the top 20 counties, whatever the metric you choose, one of the 8. And if you look at the top few, actually, they are the counties have very few population. So it's not really trustworthy, you just do the raw count. They have like a few 1,000, and then if they have 1 or 2 cases, it gets blow up. But you can search for your own county. Next, please. This is the same map last time I gave it a talk. So you can see things got quite a bit worse, right? Just visually, you know. Even some of the very dark ones is a little lack of data or things very variable and got blow up. But still, there's clear evidence things got a lot worse since 6 weeks ago. So you can search next one. So this is Philadelphia County, right? Since I'm giving a talk in Temple. You just look at the blue curve. So the blue curve, we also do prediction of cases. And deaths, usually there's a lag about 3 or 4 weeks. So deaths is still pretty calm, but the blue curve, you can see that in like October, just got picked up. There's definitely a slope going up. And on the left, you can see our confidence interval, prediction interval, still pretty decent for death. And case is not as ideal, but we don't miss too much. We didn't tune the method for case. We only studied for death, but we just use the same method for cases. And so the death is still pretty decent, around 80%, but definitely the case number is picking up in Philadelphia and in the rest of the country. Next, please. And this is new cases in Philadelphia County. The blue curve just picking up. Death is still low because there's a delay. So hopefully we know treat better. That's what I'm hoping for. Then we won't see as a huge death with the number we have. Next, please. So how Response for Life, right? We very much was doing this modeling work to help Response for Life to distribute PPEs. we went for a pretty heuristic approach. So they built a Salesforce logistics system. We end up developing this severity index. We predict at county level deaths, and we use the total number of employees of the hospital in the county to impute death count to different hospitals. And then we have the both cumulative deaths, as you said, the area severity, and then we also have the new count prediction. And then we cut into 3 categories. Both are high. We have high, medium, and low. So this is the indices the person who distribute will use, and we upload our predictions systematically to the Salesforce system, and they use it. We didn't really put into optimization. Even I recruited people to work with us, it was not called for. So we end up with this heuristic, like very categorical indices to use. Next, please. Actually, one of the shipment we did was to Temple University Hospital. 2 people I want to thank we work closely with, the founder of Respond for Life, Rick Brennan, and Don Lamworth was really the lead for the logistics. We work with Aero Bridget, like a group of pilots with planes, ship things for us because Rick is a pilot. And this is shipping on May 8th to Temple Hospital. And I think they helped us to distribute to nearby hospitals. Actually, one problem we had was we couldn't connect with hospitals at will. We call them, they don't know who we are, they wouldn't want to receive the shipment. So we can only use the places where we have contacts will receive the shipment. Next, please. So this is the Salesforce Response for Life system, and our severity index is uploaded daily, still now, but right now I think Response Life is now very active. And we work with maker spaces, maker nexus, and different local maker organizations to do. And also this get us PPEs. It's a residential medical doctors system because they have connections with hospitals to receive the shipments. Next, please. So as Edo mentioned, the paper appeared 2 weeks ago at Harvard Data Science Review. And when we submitted the paper, it was kind of, the reason actually we submitted the paper was because the website was up and running. We feel we need to make our work reproducible, and you have to document it, not just the code, but also how we did it. So that's why we wrote the paper. And for the revision, we had very, very good reviewers. So the paper became double the length. A lot of data quality results were added in the revision, not in the beginning. We just try to record what we did to support the website. Next, please. To summarize, the CLAP and the MAPI prediction interval are really generally applicable. We develop a linear exponential and some other predictors, but you can use your own predictors. Some are based on agent model, and this CLAP methodology we're able to combine and help to take the advantage of the best predictor, I would say soft way instead of hard choice way. And the MAPI methodology uses the past prediction interval, like prediction errors is also agnostic to the predictors, but you need to check a bit exchangeability for at least the period you're looking at. Over the summer, we worked on county level prediction for hospitalization, and we had UC hospital data. We really want to go to the facility level. We built a website, we didn't put public for hospital to maybe use upload the data and predict their own hospitalization. We've been waiting for data from public health department, California State. So far, we haven't had access to that data. So we're still kind of finishing the work and hopefully get some data, more data. So the same methodology works for hospitalization with different initial predictors. Moving average works much better. So we change predictors, but not this CLAP and MAPI methodology. Next, please. To summarize, so this data repository is up and running. It's always there, and a lot of people have been using it across different universities and even some research organizations, and some actually startups contact us about the data. And the CLAP and MAPI are simple, transparent, and we actually right now still upload the data, but I think response line is not as active as in March. And we also support webpage Atlas at the University of Chicago. Next, please. So we are providing our prediction to a CDC forecast hub. Now many people doing county level prediction, and we're still in the middle of finishing the hospitalization prediction with different basic predictors. I'm kind of still on the verge of doing some causal investigation, but unclear there. We have policy data and haven't really made a decision yet whether to go there. Next, please. So the codes and data up there, and the website is called covidseverity.com. So hopefully you find it useful. Thank you.
Thank you very much, Ben. This terrific work. I think the index, the paper, the repository on GitHub with data encoded in the website are going to be a tremendous resource. I also want to say this is really the quintessential data science project. It's complex, it's collaborative. Statistics and machine learning methods have been tailored to answer the right question, the important questions, and also it's mostly automated. And like you said, having more humans in the loop would be great. And so I encourage everyone here listening today to take a look at the website. Thank you again for your perspective, Ben. That's been great. I'm now going to turn it over to David Madigan. I'd like to, David Madigan recently moved to Northeastern University from Columbia University. At Columbia, he was, one of the driving forces behind the Observatory for Healthcare and Data Science and Informatics, following on that work, which is, one way to think about it is how to produce reliable and causal inferences from very complicated data sets that, all speak to the same question, but, they are hard to have them to work together. So he's an expert in this sort of area of research, and I think he's going to tell us about his more recent work on Legend, which is another project in that spirit. David, I'm going to turn it over to you. Thank you for being here.
Super, thanks, Edo. I'm very happy to be here, and slight change of direction here, unlike my fellow panelists. And I'm not going to focus entirely on COVID, although I will touch on it in a few minutes. So what I'm about to talk about is, or make remarks about, is a body of work that's been going on for 6 or 7 years under the auspices, as Edo alluded to, of a collaboration called Odyssey. And anything and everything I'm talking about you can find on the Odyssey website. The URL is there. So I'll come back in a few minutes to say some more about Odyssey, but I want to start in a different place. So next slide, please. Thank you. So what I want to talk about primarily is, if you will, a kind of a genre of work or of research in the healthcare space. So medical journals are full of papers like this one. And I'm not picking on this one in particular, it's just that it's a very good example of the genre I'm talking about. So what's going on here is a group of authors who are studying essentially a causal inference problem in the healthcare space. They're comparing different drugs, 4 of them there, apixaban, dabigatran, rivaroxaban, and warfarin. These are blood thinners. And they're looking at the risk of major bleeding in patients with atrial fibrillation, a comparative analysis of this risk across these 4 drugs. So the analysis they did, they conducted it in a very large US-based claims database, insurance database, that has, of the order of 100 million patients represented in the database. Much of the evidence that is guiding the practice of healthcare as of 2020 is coming from studies like this. It's no longer coming from randomized trials. So we have access to, we as a society, as a globally, have access now to massive scale electronic health record data, be they administrative claims databases like these good folks are using, or electronic health records that are generated during the practice of healthcare. But we now have multiple years, as I'll get into some more specifics in a few minutes, multiple years of data for hundreds of millions of people around the world, and the enterprise of generating reliable evidence about the practice of healthcare to guide the practice of healthcare from these databases is a massive enterprise, globally. So it's very important. This is where most of the evidence is coming from. So my basic point that I'm going to make is that, in a sense, the way we go about doing these studies is pretty messed up. Not to get too technical at the outset. There are real problems with the way we do this. So I want to zero in on a few of these problems. I could talk for hours about it. I won't. And then I want to describe what I think is perhaps a better way of generating reliable evidence from these large-scale databases. But before I do, let's just look at this study a little bit more closely. So, as I said, they're comparing 4 different treatments in a cohort of patients with atrial fibrillation, and the outcome is major bleeding risk. The paper, like all papers of this type, it produces a statistical artifact. So in this case, for instance, they're looking at comparing matched rivaroxaban patients, that's one of the drugs, as compared to apixaban patients. So they're doing a pairwise comparison between 2 of the drugs in here. And they're saying that the rivaroxaban patients had essentially a doubling of the risk. They were twice as likely to have a major bleed than the apixaban patients. And there are other conclusions in this paper, that's one of them. And that is exactly the kind of result that then guides the practice of healthcare in terms of which drug would you prescribe to which patient. Crucially here, they produce a statistical artifact. It's a 95% confidence interval. And the basic idea here is, what a physician or a patient or a decision maker would look at that and interpret that to mean that 95% of the time an interval like this contains the true causal effect, right? The true effect size, which we could argue about what that means, but let's just run with that. So in this particular case, the interval goes from 1.4 to 2.4, and crucially, it's north of 1, so it doesn't include 1. So a typical interpretation here would be that this is solid, this is statistically significant, and you can proceed as if there really is an effect here. Now, there's a problem, which is we don't actually know what the coverage of that interval. I've been talked quite a bit about coverage in the predictive context. Here I'm talking about coverage in the inferential context. But we don't actually know whether this interval covers the truth 95% of the time, or 50% of the time, or 100% of the time, because there are basic simple assumptions that go into the underlying math here, which we know are false. So the basic assumption is that one of them is that you have an unbiased estimator. We know that's not correct in these kinds of studies. There are many sources of bias that bedevil these kinds of studies. So work that I've been involved in, and many people have been involved in, to try and establish the operating characteristics of studies like these, suggests that the true coverage is probably in the 40 to 60% range. It's not like 93% or 96%. It's way off, right, in practice, almost certainly. So in other words, the interval, a 95% interval here, should probably look something more like 0.5 to 4. So we're proceeding as if we've nailed it, we know what's going on, when in actual fact, we really don't, because there's no basis on which to assess the coverage. Next slide, please. So that's problem number 1. We think it's 95% coverage. It isn't. Kind of demonstrably, it's not, and therefore decision-making pursuant downstream from this is sort of intrinsically unreliable. Next, please. Another problem with these kinds of studies is they're not necessarily pre-specified. You actually have no idea what these authors did, what the process was that yielded this egg, if you will, that they lay, in the paper. And in particular, you don't know if the analysis that they're reporting here was pre-specified. So did they try 20 different analyses and choose the one they liked? And it's not necessarily nefarious. They might have thought it was the best analysis, but there's no suggestion in here that it was pre-specified. That's typical of these papers. Next slide. Is it reproducible? I guarantee you it's not. meaning if a second group of authors set out to, to run this analysis and reproduce these numbers, they couldn't. And there are many reasons for this. It's a complicated, interesting societal problem. But let me give you one little kind of insight or snippet as to why you can't reproduce a study like this. There's a statement in the paper, very typical of this, that talks about baseline patient characteristics that included age. Okay, that's fairly well defined, maybe, although you don't know whether they categorized it or not. Gender, geographic region, how defined? Clinical characteristics and baseline medication use. Good luck trying to reproduce that. And it's essentially completely impossible. Next slide. Is it generalizable? Does this apply to me? Does it apply to you? So this model, this analysis was conducted in a US-based claims database, so people who are insured in the United States. Does that apply to people in Korea? Does it apply to non-insured people in the United States? So the major questions about the generalizability. Next slide. In essence, the process right now that produces these kinds of studies is entirely kind of artisanal. It's like it's an arts and crafts kind of a business. It's you're relying on the skills and the scientific kind of prowess of the folks doing the analysis. It's like, and I've literally heard this. Trust me, I'm a good analyst. I know what I'm doing. It's a good result. So it's a very unsatisfactory state of affairs in terms of generating this is the evidence that's guiding the practice of healthcare. It's really quite scary. Next slide. So I hope I've given you a flavor of why the current state of affairs is in very many ways problematic. So now I want to switch gears and talk about a new approach that we call Legend, that has been developed in the context of the Odyssey collaboration. I don't for one second think this is the last word or the best way of doing this, but I think it has characteristics that are desirable, and I'm hoping it leads to a significant improvement in the way we generate evidence going forward. So what we sought out in developing a new approach is we wanted something that was reproducible, so you could go back and literally perfectly reproduce any analysis we do. We wanted it to be systematized, so none of this artisanal, I decide to adjust for this and I decide to exclude that and so on, but a systematized approach that is essentially automated and done at a very large scale and entirely open source. So that the code is available, the protocol is available, completely pre-specified analysis is what we sought out. A key aspect of the approach, or a key characteristic, is the use of negative controls. So this is not a new idea, it's been around for a long time. The Legend studies are doing it perhaps on an unprecedented scale. Basic idea is very simple. Let's imagine we're studying drugs, it extends to other medical interventions. But a negative control is a drug and an outcome where it is, quote unquote, known that there's no causal association. Okay, so there's a bit of a circularity to this, which is if we don't know how to do this causal inference, how do we know that something doesn't cause something else? Suffice it to say that we have developed a very large scale, algorithmically driven approach to identifying negative controls. We could have a good argument about how good it is, but it's at least a step in this direction that is transparent and reproducible. We derive these negative controls from very large scale literature crawls, from structured analysis of product labels, and also analysis of so-called spontaneous reports. Therein lies a lengthy story in and of itself. We identify negative controls. This enables us to produce what we refer to as empirical p-values. So rather than statistical artifacts that rely on wildly unrealistic assumptions, we simply generate statistical artifacts from basically how well do these methods do on the negative controls, where we quote unquote know the answer. It's a long story, and I'm happy to provide references to the various papers that describe it in detail. We also utilize positive controls, which are drug outcome pairs with a known effect size, and our current approach is to simulate these using very large scale models that enables us to produce calibrated confidence intervals. I would describe this as a work in progress. There's a lot to be done. Next slide, please. So let me just give you a quick flavor. I don't have a huge amount of time. Let me give you a quick flavor of this approach in action. So in 2017, the American College of Cardiology and other organizations produced new guidelines for the management of hypertension. Hypertension is extremely common in this country and around the world. This guideline is hugely important in terms of the actual practice of cardiologists and physicians in general in managing hypertension. 56 pages, 106 recommendations. They very carefully discriminated between recommendations that were expert opinion, and then they had gradation from all the way from expert opinion to guided by randomized controlled trials. Next slide, please. Next slide, please. Thank you. So in this guideline, they considered, if you look at all the different treatments, pharmaceutical treatments they considered for hypertension, there were 39 different drugs that they considered in this analysis. They formed different drug classes, but 39 different ingredients. And the slide there on the left, or the circle on the left, just shows you how common these different drugs are in a particular database in the United States. So it's kind of the Wild West in terms of the array of drugs that's used for hypertension. Next slide, please. So they considered 39 treatments in the guideline. 58 different outcomes of interest were mentioned. So these range from bad effects of these drugs, adverse effects, to good effects of these drugs. There are 58 of them. Next slide, please. The 39 drugs are arrayed around a circle here on the top half of this slide. And what we've filled in here is we've put in a line inside this circle for every head-to-head comparison of a pair of drugs for which there is evidence from a randomized trial. So as you can see, there's a huge dearth of evidence. And indeed, many of the recommendations in the guideline are based on expert opinion, what experts think, rather than actual evidence. So our goal in this, in the LEGEND study we did on hypertension, it's one of several we have done, is to basically go from the left-hand side to the right-hand side. We wanted to fill in the circle and generate reliable, reproducible evidence with known operating characteristics for every possible pairwise comparison in this circle. You can't actually do all of them because even though we're dealing with very large-scale databases, you run out of data for many of the comparisons for the less widely used drugs and the less common outcomes. But in any event, it's over 10,000 comparisons. We conducted this study globally. So what we did is we did a head-to-head comparison of every pair of drugs, that's 39 choose 2, for all 58 outcomes, using negative controls and positive controls in an array of databases that are listed there, that they don't cover the entire globe, but it's a few 100 million patients in different parts of the world. So US, Japan, Korea, and Germany included in this. The full Odyssey network, I'll get to it in a second, I'll talk about it briefly, is bigger than this, but this particular study we conducted in these databases. Next slide, please. I think there might have been a second slide there. There we go, thank you. So here are the results, so to speak. So in the end, our study produces 1.3 million estimates. So we're doing what some folks refer to as the all by all, right? All pairwise comparisons of these hypertension treatments. We're filling in the circle, right, for all 58 outcomes. And let me orient you quickly with this picture. The horizontal axis is the point estimate, where a hazard ratio of 1 is the neutral value. The vertical axis is the standard error. And these dotted lines give you that's the boundary for classical statistical significance at the 5% level. For this analysis of that 1.3 million estimates, 83% of those confidence intervals include 1. It's not 95%, but it shouldn't be 95% because one assumes that many of these are real effects. But every single dot on this study is backed by full automated diagnostics and actually a full paper. So we can generate 1.3 million scientific papers, and have done, that describe every single dot in this picture. Now, that's what it looks like, basically, if instead of cherry picking and studying one thing in an artisanal way, basically fiddling around and producing a result, This is a systematic, automated, complete analysis of hypertension drugs for these 58 outcomes. Next slide. Keep that picture in your head while I go to the next slide. That's what the literature looks like. So if you do a crawl, which we've done several times, of the literature of observational studies, that's what it looks like. There's disastrous clustering just under the 0.05 level. This is p-hacking, right, that we all know about and talk about. So go back a slide, please. Actually, if you could just go backwards and forwards a couple of times, please. That's what it looks like when you don't have, you're not doing pre-selection and fiddling around. That's what the literature should look like. Go forward a slide. That's what it actually looks like. We have a problem. We have a real problem. Next slide, please. Oh, sorry, I should have said it before I get there. In the previous slide, 85% of the results were statistically significant. When you do this more honest, I would claim, analysis, it's the other way around. 85% are not statistically significant. I invite you to look at that. It was published in Lancet a few months ago. There's several other legend studies that are either published or in the works. So briefly, this is in the context of a collaboration called Odyssey. So the Odyssey is a community. It's a global community that is basically studying these kinds of analysis and trying to come up with better methods for generating more reliable evidence from large-scale healthcare data. Next slide, please. There are about a couple of thousand people around the world who are active in Odyssey. There are dozens and dozens of working groups within Odyssey. There are Odyssey symposia in ordinary times. In Europe, in the US, in Asia, there are sections all over the world. Odyssey members, many Odyssey members have clinical data. They sit on data. The union of those databases has about 700 million patients in the databases. So conceivably, you can do an analysis with about 10% of the world's population and growing. The reason why this club is so to speak, how I think of Odyssey, is growing rapidly and gathering such steam is a common data model. So we have developed something called the OMOP common data model. All of these databases, it's now around 100 databases around the world, have been mapped to the common data model so that you can write an analysis, implement an analysis. There's a huge open source library to help you do that the community has developed, and deploy it anywhere in the world on any of these databases that has been mapped to the OMOP common data model. Next slide, please. Briefly, the community is looking at population level estimation. That's what I just talked about. But there's also a huge amount of activity related to patient level prediction, personalized medicine, if you will, precision medicine in these databases. And also a lot of very interesting work going on in clinical characterization, trying to understand the practice of healthcare now that we have data on this kind of scale. A quick mention of COVID. This kind of asset, if you will, and network around the world is tailor-made for studying things that are where you want to do rapid, large-scale studies. So the community has developed an outpouring of papers using the Odyssey network studying COVID. And these are just a few of them here that have been produced in short order. Next slide. So finally, what I'm really talking about here is the power of an international community and a truly global data network. I believe that we are using it to generate real-world evidence, in a much more reliable. We're not, this isn't the last word, but I do believe it's more reliable and certainly reproducible than the classical artisanal approaches. The common data model here can't be underestimated in terms of the power. You can't do this kind of science without a common data model. Obviously, if you had to write the code 100 times for 100 different databases, you're dead in the water. It can't happen. So the power of the common data model is absolutely amazing in terms of advancing science in this area. But needless to say, much work remains to be done. I invite anyone listening to this to go to the Odyssey website and join. Just join means just sign on to one of the working groups or the forums or whatever. It is an open and welcoming scientific community. Thank you very much.
Thank you very much, David. I'm a big fan of this thread of work, and I think the idea of negative control hasn't been leveraged enough really in any area of science or industry where wild predictions abound, coming from complex databases. So thank you for reminding us on that. It's not just used for estimation, but I guess a more reliable model is also better, more generalizable and, better for other sample predictions, I imagine. Right? Okay, so we did receive a number of questions, but unfortunately we are running out of time for this panel. So I will just say, on behalf of Temple University, the Department of Statistical Science, the Fox School of Business, our partners at Wells Fargo, thank you very much to Nicholas, Bean, and David for presenting our perspectives here today. Thank you for your time. Really appreciate that. Thank you.
Thank you.
Thank you very much.